Hi everyone, very good evening guys. Am I audible and visible to all of you? Just let me know a quick thumbs up in the chat box, and if yes, then we can proceed without any delay. Also, just having to let you all know, and I think you are aware that on 2nd of February at 9 o'clock, 2nd Feb 9 o'clock, there's a test which is going to comprise of 30 questions, and this will be conducted on the Unacademy app. This test will be free for everyone to attempt, and this will be followed by written solutions which will be provided to you, so you can join in on 2nd of February. And yes, what is the purpose of the session that we are conducting right now? Two things. First, I wanted to discuss with you the plan for February, everything, whether it is the Kickstart morning sessions, or it is the plus classes, or whether it is the YouTube session. So how are we planning it for both the NEET PG students as well as the FMG students? What's the plan that is currently going to be, in Feb? So I'll be discussing that. And since we have come live and we've met, so might as well discuss also some questions. So I think with a fresh mind, let's begin with some questions only, because the scheduler is something which I just have to go through in the end, and I'll pass it on Telegram also. So there's nothing very fancy about it. You know that all the remaining topics will be covered in Kickstart Morning and YouTube, Micropath both. But I think questions are something that we are all looking out for, and we should definitely attempt those first. So all good guys, let's start with this session. The session is going to time out to approximately 1 hour. So I hope all of you are ready for it. So let's begin with question number 1, which is here. So it's a GIF based question, and they've given you a machine, and they've asked you what is the ideal temperature based on whatever you think is this machine. So you can let me know what is the ideal temperature that is maintained inside it. So I'll give you a time of approximately, there's no timer, but a virtual time of approximately 15 to 20 seconds is enough. Okay, most of you have already gotten the answers. This is, as you can see, the plates are moving. This is a constantly agitating machine. So the constant agitator machine is referred to as the platelet agitator. If you ever happen to go to a blood bank, this is definitely a machine that you will see in the blood bank. So if you ever happen to go, please do look at it. That's somewhere this machine which is moving left and right, that is an agitator. So platelets always, a platelet bag, a bag of platelets will always be kept in this agitator. Why does the platelet constantly have to move? Because please remember, if you don't agitate the platelets, they'll start clumping, they'll start aggregating, and you don't want the platelets which will be given to a patient should be aggregated in this way. So you want constantly keep on moving the platelets. Now, what is the temperature that we'll maintain? So if you ever happen to visit a blood bank, you will see that there's a screen over here on which the temperature will be displayed, and platelets are always kept at a 20 to 24 degrees Celsius. In fact, one of the highest temperatures on which a blood component is kept is a platelet only. Platelet is kept at 20 to 24 degrees Celsius, and the shelf life of platelets is going to be 5 days, but it comes with a caution, and that is you keep it at 20 to 24 degrees Celsius for 5 days, and that's the shelf life, provided you've kept it in this agitator. Provided for 5 days the bag is constantly 24 hours being agitated. However, if there is no agitation, or if this machine, for example, stops, these plates stop working, if there is no agitation, this was a question that came in 2019 also, that if there's no agitation, AIIMS mein pucha tha. So please remember that ideally the platelets will start getting aggregated in 4 hours only, but still they say that you can keep the bag for a maximum shelf life of 1 day. So maximum shelf life that I have, that is going to be 24 hours. So remember, 5 days is the usual shelf life, but it comes down to only 1 day if you do not keep it in an agitator machine. So clearly the answer over here was 20 to 24 degree. Tell me the answers to the other options also. What is kept at a 2 to 6 degrees Celsius? Which blood component is kept here? So 2 to 6 degrees Celsius is everything to do with red blood cells. So this is basically like any other regular refrigerator. That's the temperature of a regular refrigerator, 2 to 6 degrees. Packed red blood cell, or anything that has red blood cell, like even whole blood. Whole blood also has red blood cells. So 2 to 6 degrees for that. Whereas temperatures which go in minus, obviously they are the ones which are used for fresh frozen plasma. So the word only has frozen in it. So less than -18, anything below -18 is what I prefer for fresh frozen plasma. So these are the minus temperatures. Done with this question, let's move on to question number 2. Again a GIF where a mechanism is being depicted and you have to tell me which of the following steps written over here is being shown out here. Have a look at it again. There's a cell and I can see that cell is kind of moving somewhere. Perfect. So many of you have got the answer ready with you. So if you see, this is a blood vessel, a capillary as it is labeled. There's a blood vessel going. Okay, some of you have said rolling and some of you have said chemotaxis. The right answer to this question is chemotaxis. See, you need to analyze where is the cell. First, let's get familiar with this picture. There's a thorn or a prick that has happened in the skin. So there's some foreign body, some bacteria in the skin that have come from outside. Now this is a cell which is outside the blood vessel. It has moved outside the blood vessel and it's moving towards the bacteria. So have a look at it again. This is a particular cell which has come out of the blood vessel and it's moving towards the bacteria. So when a white blood cell moves towards the bacteria in a single direction, look at the direction, very focused, one direction, in a unidirectional manner, that step of inflammation is said to be chemotaxis. That's the definition of chemotaxis. Chemotaxis is unidirectional movement from the white blood cell to the bacteria. Okay, and yes, most of you have got it right. Some of you said rolling and adhesion. Rolling, some of you said, but remember, rolling and things will happen inside here, inside a blood vessel. Rolling, adhesion, these are all steps happening inside a blood vessel. Here, the cell has already come outside. So, you'll think of steps outside a blood vessel. Coming to the next question. Again, a picture with a GIF. And they've asked you that there's a method of sterilization, how they've opened the lid, how there's something like a heat that is happening. So they've asked you, what is this? Spin it, open it, and then a process is going on inside. Method of sterilization shown below. Dry heat, moist heat at 100 degree, moist heat above 100 degree, or filtration. So I think definitely, as you see over here, if you are seeing this image well, certainly you see that there's a lid that's opening. It's a horizontal machine that you have perfectly put up, right? Very good. This is an autoclave. Right, so usually there are different types of autoclaves. You might feel that this is not the autoclave that I've seen in my lab, or this is not the autoclave that we see in my OT, because autoclaves can have multiple orientations. If an autoclave is the standing autoclave that you've seen, then you've probably seen the vertical autoclave in your laboratories. If the same one has been put in this horizontal manner, I'll call it a horizontal autoclave. Sometimes the manufacturers give it in a different shape. Sometimes it looks like a pressure cooker. Sometimes it also looks like an oven or a microwave. So that's the common one that we use. So different shapes are known, but the biggest one is the automatic hospital autoclave, which is obviously used where the workload is too much and they need much bigger capacity for the autoclave. But the two most common ones that you'll find will either be this vertical wala or the horizontal wala. And this is what the GIF told you. The GIF showed you a horizontal autoclave. See, they've opened the lid and whatever glassware, flasks you want to keep, you keep them inside the lid. And can you see how there is a temperature, the heat is coming and there's a flask that is kept over here, how the heat has just tried and sterilize it. So this is definitely moist heat above 100 degree, because firstly, why moist heat? Moist heat because autoclave में steam generate होता है. So it's not just regular heat, steam generate होता है, there's dry, moist heat in it. And above 100 degree because this is performed at 121 degrees Celsius. The minimum time that I have is 15 minutes and the pressure that I maintain it at is 15 pounds square inch. 121, 15 minute, 15 pounds square inch. And if I want to do the control and if I want to find out that whether this worked well and this temperature was maintained and everything went fine, then what is the control that I would want to use? And something that they always ask you, there's a biological control. Whenever I say that there's a biological control, means they've used some kind of a bacteria to find out that was the control working fine, was the test working fine. And the name of the control is Bacillus stero-thermophilus. Bacillus stero-thermophilus. So actually what happens is, I'll tell you like the lab that I'm working in. So what do we do on a daily basis? How do we make sure that our autoclave is working well? Whenever we run, like for example, we have this autoclave, we put all our glasswares in it, whatever samples we want to autoclave, whatever we want to autoclave, we put in it. And along with that, there is a strip or there is a Bacillus stero-thermophilus that the company gives to me, that whenever you do one cycle of autoclave, put this also in it. So ideally, this is, see, the name tells you thermophilus. This will be killed at very high temperature. So ideally at 121 degrees Celsius, when my autoclave is functioning, this should get killed. But how will I get to know that this is, this is killed? So sometimes there are some color changes that happen which help me know that, yeah, this organism has been killed. Sometimes the same strip, after my autoclave is done, I send it to the microbiolab. I send it to the microbiolab and I tell them, try to grow this organism, culture hua. And if they say that nahi, culture nahi hua, this means the organism had died and my procedure worked well. So the organism died and that is why it did not come in the culture. So that is another check that I can do, that my autoclave is working well or not. It's one of the most important controls that you have, which you have to put up every time you run an autoclave to know that whether you actually achieved a 121 degree or not. It's a very important indicator. Let's move on to the next question. So moving away from the GIFs, let's go on to a theoretical question. Culture will take time, definitely, Dr. Costa. Usually in labs, it takes 48 hours for the report to come. That is why in most of the cases, color indicator works very well, because color indicator tells me biological control is not the only thing. We also have a chemical strip. A chemical indicator is also put in an autoclave machine, because side by side, the chemical indicator gives me an instant control that yes, everything color change hua, it tells me that it was working fine, but I want to be double sure. So I also put a biological indicator, and that I confirm from a microbiology lab. It takes about 48 hours for the report to come, but then at least I know that everything in my lab is standardized. Okay, everyone, let's move on to the next question. 35-year-old woman complains of nipple discharge and irregular menses of 5 months duration. Physical examination reveals milky discharge from both the nipples, and MRI shows an enlargement of the anterior pituitary. Which of the following is the most likely histological diagnosis? Okay, so I think that's quite an easy one, I suppose. This is a typical question which will come when they want to test your basic general path knowledge. So first and foremost, if they were wanting to give me a question of a papilloma, firstly, pituitary में papilloma is honestly, I've never heard. Seeing a pituitary papilloma, I've never heard of such a term. So this is not going well only. Papilloma is something that would happen on the skin. So a skin papilloma, yes, or an anal papilloma. These are the common sites. Pituitary papilloma is unheard of. But still, if they give me a papilloma, some papillary projections will definitely be mentioned, which was not given in the case. When they want to talk about a teratoma, I think everyone knows hair, skin, teeth, bone, these kind of things will be given. Again, pituitary and teratoma, not a very common combination. Now let's talk about hamartoma. Day before yesterday, I uploaded one YouTube session and we discussed hamartoma. Hamartoma is native tissue proliferation. Hamara tissue, that is how we learn it. Hamara tissue or native tissue proliferation is hamartoma. Here nothing was proliferating. Choristoma. Choristoma is referred to as ectopic tissue. How do we learn choristoma? Choristoma is chorica tissue. So some ectopic tissue. So they didn't mention anything like that, that in the pituitary some other organ or some other tissue has come up. Nothing of that sort was mentioned. This was a classical case of pituitary adenoma, because firstly I can see that this was also functional. Why do we say that? Because there is two complaints that the female has come up with. There's a bilateral nipple discharge, so most likely she's suffering from galactorrhea. Also, she's complained of irregular menses, which kind of explains that her prolactin levels were definitely higher, and prolactin was higher, so menses became irregular, nipple discharge happened. And if this is a functional tumor, so basically we are dealing about a prolactinoma, which is nothing but an adenoma. So which tumors, now you know pituitary adenomas are of two types, micro and macro. What's the cutoff that a radiologist uses for a microadenoma versus a macroadenoma? The cutoff is 10 mm, right? I think this is basic, which everyone knows. Less than 10 mm, radiologist will call it a microadenoma. More than 10 mm, radiologist will call it a macroadenoma. Which of these tends to be usually, I'm not saying 100% rule, but usually functional ज़्यादा कौन सा होता है? Which of them is a more functional one? A more functional one is microadenoma. So the smaller ones usually tend to be functional. They functional matlab they will be the ones releasing some hormone. Like in this case, prolactin seems to be a hormone, so I'll want to call it a prolactinoma. So certainly this was a case of adenoma and not the others that we had. Let's move on to the next question there onwards. Let's read. Cytogenetic studies of a 40-year-old woman with follicular lymphoma demonstrated a translocation 14-18 chromosomal translocation involving the BCL2 gene. Constitutive expression of the protein encoded by BCL2 gene inhibits which of the following processes in the patient's transformed lymphocytes? So they've been very kind to you. They've given you the lymphoma, they've given you the translocation, they've given you the protein also. They're just asking you the function of that protein. Perfect. So again, these are questions where I want to tell you that the pattern has definitely changed, but that doesn't mean that you forget your basic knowledge. Earlier, what has changed? Earlier, they just used to ask you, is BCL2 pro-apoptotic or anti-apoptotic? The questions were one line. Now they've put it up in a proper history, correlated it with a patient, her genetic profile, and now asked you the same thing, that what is it? It is anti-apoptotic. So what is it asking you? It inhibits what? It inhibits apoptosis. So please remember, in a case of follicular lymphoma, as they've told you, there is translocation 14 and 18. Because of translocation 14 and 18, there is increased expression of BCL2. BCL2 expression increases. And I think everyone has studied one basic thing in general path, that all the alphabets, all the names which have the alphabet L in it, they lower apoptosis. Means they are anti-apoptotic. So clearly over here, and that kind of makes sense. See, I have a patient who's got lymphocytes. You and I, everyone has lymphocytes. It's such a normal cell in the body, right? But after a certain while, the lymphocytes will die and then new lymphocytes will form. That's the cycle of every cell. But imagine someone having too much of BCL2, which is anti-apoptotic, which is not going to let your lymphocytes die. These lymphocytes will then never die, anti-apoptotic. They'll keep on proliferating, dividing. Will they ever die? They're not going to die. And if the cells stop dying, I'm definitely in for a tumor. I'm definitely in for a cancer then. And that is the reason the lymphocytes keep on staying, they don't die, and patient lands up with a follicular lymphoma. So certainly over here we have BCL2. Now let's revise all this. General path, thoda sa revision is always needed. Which all are the pro-apoptotic factors? Which all are the anti-apoptotic factors? And then we'll come back to that question, because we also have to revise for the exam all the translocations. So let's finish this off. So first, like I told you, everything that has L in it, BCL2, MCL1, and BCL of which type? See, there are lots of BCLs, XS and XL. Again, BCL of the XL type. So everything with L in it is going to be lowering apoptosis, is going to be anti-apoptotic, versus P53, BACs, BCL of XS type will be pro-apoptotic. So one thing is certain, that if someone just mentions BCL family, I cannot select anyone. BCL family comes here also and comes here also, both. But if they tell me which member of the family, if they tell me BCL2, BCLXL, these are anti. If they tell me BCLXS, then that is pro-apoptotic. Now coming back, they gave me a very important translocation over here. That was 14 and 18. So definitely that is follicular lymphoma, but all time that you have to learn are the translocations of lymphoma. And whenever you want to revise, whenever you plan to make a revision chit of this particular topic, just write down 4 numbers in front of you. These 4 numbers are going to take care of all your lymphomas that you'll have. So first and foremost, 8, 11, 14, 18. 8, say, I think you know which lymphoma I'm going to talk about. It's one of the easiest, right? 8 looks like a B. So I am going to talk about Burkitt's lymphoma. I'm going to talk about Burkitt's lymphoma out here, right? And the rule I think everyone knows, that 8 has to combine with an even number. That's the rule that I have to follow. So either 8 is going to combine with 14, or 8 is going to combine with 22, or 8 is going to combine with 2. So these are the possible translocations that I have. Either ways, 8 has to combine with an even number in that case. What is with 8? ऐसा क्या है on chromosome 8 which is so characteristic of Burkitt's lymphoma? Please remember, chromosome 8 has c-MYC. Chromosome 8 has c-MYC, and don't we study that in Burkitt's lymphoma there is c-MYC amplification that is noted? So now you understand why, because chromosome 8 is involved everywhere. Having said that, now I'm left with 11, 14, 18. So if I ask you which is the best lymphoma, like if a person is asking for a lymphoma, which is the best lymphoma that he can ask for? The best one, I mean, good prognosis, where his survival will be very, very good. And the most friendly and good lymphoma a person can have is a follicular lymphoma. So follicular lymphoma patients, we are like pretty confident that their overall survival is going to be good, unless it transforms and it's an end stage is a different issue. But yeah, overall follicular lymphoma is a good prognosis. So I always call follicular lymphoma as my friendly lymphoma because it's prognostically a good one. Friendly matlab teenage, 14, 18. Teens will always be friends, right? So whenever I'm dealing with translocation 14 and 18, I am dealing with follicular lymphoma, translocation 14 and 18. After that, if I pick up the ones at the margins, guys, what have I written at the margins? 11 and 18. If I pick up something called 11 and 18, because I've picked up numbers from the margins, this is a marginal zone lymphoma. Translocation 11-18 is known as marginal zone lymphoma, and if this marginal lymphoma say happens in the stomach, what is the name given to it? Marginal zone lymphoma in the stomach, in the intestine, in all these places it is known as a maltoma. So maltoma of the stomach is same as a marginal zone lymphoma 11 and 18. What combination am I left with? I'm left with only 11-14. So translocation 11-14 is seen in mantle cell lymphoma. Translocation 11-14 is seen in mantle cell lymphoma. Every time you revise your topic, please revise it this way. You write these numbers. 8 is very clear because it will remind you 8 and even number Burkitt's. Then you write down 3 numbers: 11, 14, 18. 14 and 18, teenage, friends, follicular. 11 and 18, margins, marginal zone lymphoma. Left with 11 and 14, and that is mantle cell lymphoma. I hope that's clear. The translocations are sorted because they are all-time favorite. Coming to the next question. The tumors causing thrombosis are all except the word that we usually forget to read. Except. So you need to tell me which of them does not cause thrombosis. Which of them does not cause thrombosis? Right, so I've got an answer. First answer that I've got is C, and that is breast cancer. So usually, this is a very primitive question. Somewhere in second year beginning, whenever you're reading thrombosis wala chapter, this usually comes up, and there's a very simple mnemonic that they've given. Thrombosis is something that is caused by which cancers? The SLAP tumors tend to cause thrombosis. Yes, a very famous mnemonic which I'm sure all of you know. SLAP tumors, that is stomach cancer. Stomach cancer causes thrombosis. Lung adenocarcinoma causes thrombosis. Pancreatic cancer and prostate cancer causes thrombosis. And APML causes thrombosis. So I want to ask you one thing. So many tumors can occur in the lung, like lung can have squamous, adeno, small cell, large cell. Stomach can have a variety of tumors. Same for pancreas, same for prostate. But what is the common tumor out here that I'm talking about? The common tumor that I'm talking about is adenocarcinoma. I'm saying adenocarcinoma stomach, adenocarcinoma lung, adenopancreas, adenoprostate. Why so? Because adenocarcinomas are very famous for producing mucin. When mucin production will occur, you all should know from your general path that mucin is thrombogenic. Mucin is very famously known for causing thrombosis. So mucin is thrombogenic. That is something you should know. So automatically all of them will cause thrombosis. What about this one? What about APML? It's not an adenocarcinoma. This is a blood cancer. Acute promyelocytic leukemia. Is this AML-M3? Indirectly, that is what I want to say. Is this the only leukemia which can cause clotting and thrombosis? Yes. So I think everyone knows this is the only leukemia which can lead to DIC in a patient because this releases some procoagulant factors. APML, just like all these adenocarcinomas were releasing mucin. Mucin is a procoagulant factor. It can activate the clotting pathway. Similarly, APML, the promyelocytes, they can also release some pro-clotting factors and that will cause clotting all over the body. So APML, prostate, lung, all of them can cause. What is not associated with thrombosis? The answer, as all of you told me, was breast cancer. Okay, having said that, let's move on to the next question. The next question is, once upon a time, such questions used to come in PGI when we had the PGI paper. Now it can come in the INI CET where you will be asked to select multiple options. And this used to be the PGI favorite question. Every year or alternate year, this was coming, mandatory hota tha. Which of the following is seen in Alzheimer's disease? Let me know whatever you feel is correct. Whichever combination, A, B, A, C, B, C, B, D, whatever. So, okay, most of you say, the answers that I'm getting, I'll write down. Most of you say B, D or B, C. Abhi tak, these are the answers that I've got. Okay, so B, D and one or two of you saying, basically everyone's roaming around between B, C and D as I see. Some of you are saying E, which I don't see as an option. Acha, there's no one who said all of the above, because if I would have given a fifth option and written all of the above, then all of you would have said, ma'am, all of the above is always the answer. I did not give it like that, but the answer is all. Guys, all of these are features of Alzheimer's disease. See, okay, I understand you are very fond of neurofibrillary tangles and that is what you study the most. Doesn't mean that the other things are not seen. Everything of this. So this actually came as a PGI question and A, B, C, D was the answer and A no one selected because we hardly read this much of depth of Alzheimer's and that is why people used to get this wrong in the PGI exam also. But all of these are seen. So let's study. When I'm dealing with Alzheimer's disease, there is something that I definitely, in fact, one of the findings is missing here. Any bodies that are missing here, then the entire spectrum will be complete. All the entire, any bodies which everyone knows which you see in Alzheimer's disease, even Hirano bodies are seen. So that is actually the 5 spectrum things of Alzheimer's that was there. Okay, Dr. Amit selected A, very good, but actually sab kuch tha. Okay, so if you selected A, then this means you've read the topic very, very well and that is amazing. So chalo, let's see one by one. When I talk about Alzheimer's, does everyone agree that Alzheimer's has the production or formation of beta plaques? And these beta plaques deposit in the form of amyloid. This information we know that these beta plaques have A beta type of amyloid. So I'll see a particular body where there will be amyloid in the center, that is beta plaques in the center, and the nerve processes will be seen around it. The nerve processes will be seen around it. So till the time only amyloid was there, I was calling it an amyloid plaque, beta plaque. But now when around it, I see some neuritic processes, together I call this a neuritic plaque. That's the first picture that you have to see over here. Just focus on image number 1 for the time being. Firstly, tell me the stain. Whenever I want to see these neuritic processes, like over here, see in the center, you don't see too much of brown color because that's that amyloid wala core area. And at the periphery, you see all these nerve fibers, the neuritic plaques. So this is a classical neuritic plaque. And whenever I want to see a neuritic plaque in the brain or I want to see neuritic processes, the stain that I use is the Biel-Chavsky stain. It's a Biel-Chavsky stain. If someone asks you the utility, it is utilized for seeing these neuritic processes. Okay, having said that, after this, so neuritic plaque I've understood, right? Let's move on to the next question, the next image. The two images that I have, this cell also looks like as if it's on fire, it's a flame, and so do these cells. Stain why use hua hai over here, the Biel-Chavsky stain. But what is this cell? So because it looks like a flame, you can definitely call it a flame cell. But what's the actual name of a flame cell? It is NFT. not the NFTs that you are seeing over social media nowadays. The NFT over here is neurofibrillary tangles. It is neurofibrillary tangles. So now you'll want to ask me that what are neurofibrillary tangles made up of? So that's a question that used to be. So this was always, an AIMS PGI kind of a favorite. So PGI में तो multiple options आता था. AIMS में they used to ask you the composition of neurofibrillary tangles, and that is the tau protein. That is the tau protein is the neurofibrillary tangle ka composition. Right. So I think neurofibrillary tangles was mentioned in the question, and that is also my answer. Next, what bodies can you see? You see Hirano bodies. How do Hirano bodies look? Image number 3. These are a little elongated like a needle. These are referred to as Hirano bodies. And if you ask me what are they made up of? Hirano bodies are made up of actin. That's the composition that they ask you. So they are made up of actin. So 1, 2 and 3 pictures are very clear when it comes to Alzheimer's. But there were 2 more things which you need to know, but you don't get them as images. You need to know them as theoretical points. The cells show you vacuolar degeneration. The cells show you vacuoles. So granulovacular degeneration is a rare but a change that you see in Alzheimer's, vacuolation of the cells. And you will say that, ma'am, this amyloid that you told us, is it only affecting the nerve fibers? No. This amyloid is also affecting the blood vessels. So do you see cerebral amyloid angiopathy? Correct. Please remember, all of these are seen in a case of Alzheimer's. I'll repeat 3 pictures. Number 1, if you see unlabeled, number 1, neuritic plaque. Number 2, neurofibrillary tangles. Number 3, Hirano bodies. Other than that, you also see the blood vessels getting affected, cerebral amyloid angiopathy, and vacuoles in the cell. All 5 are seen. Now, having said that, one last question. Which type of A beta is going to, what are the isoforms of A beta that cause Alzheimer's disease? Please remember, A beta 40 and A beta 42 are the numbers that you have to learn. A beta 40, A beta 42. What are the questions that I can get with these isoforms? Please remember, if someone asks you which type of amyloid or beta plaque starts all of Alzheimer's, if someone asks you which is the key initiator of Alzheimer's disease, please remember, key initiator of Alzheimer's disease is the bigger number. The bigger number is like a big brother who's taking the lead and is starting everything. So this big number, bigger brother is, elder brother is taking the lead and is starting all of Alzheimer's disease. Versus then what is this younger brother doing? A beta 40, the smaller number. This is very much responsible for this blood vessel wala problem. The cerebral amyloid angiopathy, the blood vessel related issue of amyloid and Alzheimer's that is happening is because of this younger brother. So remember, the elder brother 42 takes the lead and starts all of Alzheimer's. The younger brother is involved more in the blood vessels. That is what you need to know about this, and I hope next time you won't be getting it wrong. Okay, coming to the next one, an all-time favorite, easy question that comes from hematology, but you can call this the examiner's favorite question. Evergreen examiner's favorite, where they ask you what are Dole bodies and what is the exact organelle which is made up of. And I think everyone would know this. Perfect. So the answer to the question becomes the first one. Dole bodies. So first I'll directly show you a picture out here. Have a look at this. If you look carefully, first tell me what kind of a cell is this. Something like this I taught you in yesterday's YouTube session. So I think you should be okay with what cell is this. This cell out here. Answer sabne theek diya, but identify the cell. This happens to be see, it's looking like a total band, like a hairband. It's looking like a hairband. Very good. So I call this a band form, or some people also call it a stab form. Band form or stab form. Is it, where do you place it? How many steps before a neutrophil? It is just one step before a neutrophil. Matlab mature neutrophil se one step pehle I get a band or a stab form. In this band form, I saw that there were some big dots that were present in the cytoplasm, and these are referred to as Dole bodies. So 2 questions come to my mind. What exactly is a Dole body? So I'll take the first alphabet and the last alphabet. So remember, Dole bodies are nothing but dilated endoplasmic reticulum. Dilated endoplasmic reticulum. And when do I see them? Dole bodies are usually seen in very severe infection, or sometimes I can call that as sepsis. Severe widespread infection is going to be Dole bodies. So you know the reason for Dole bodies and you know the composition of the Dole bodies. I think that's a question which is, what can I say, all-time favorite. Coming to the next one. Okay, so there's a 23-year-old female who presents with vaginal bleeding showing a red friable mass in the vaginal wall. The histological assessment of the same has been shown to you, and exposure to which of the following would be associated with this? Dr. Aishwarya, no. Dole bodies can be seen in any stage of the neutrophils, any mature neutrophils also, and before that band and metamylo, किसी भी stage में, any stage of the myeloid lineage can show that. Okay, so coming back to this, most of you have selected, there are two options that I've got, actually three now. Some of you have said tricho, some of you have said human papilloma virus, and some of you have said DES. At least no one thought candida. Either I can also not see candida. So candida, let's rule out. No one thinks this is candida. Why did all of you think trichomonas? See, when I'm dealing with, there are two things. Whenever I'm dealing with a parasite, and remember that, like I'm dealing with a parasite, or I'm dealing with a fungus, or I'm even dealing with a bacteria. So bacteria, parasite and fungus should be visual to me. Means if you're talking about candida, show me the candida over here. Show me the budding form. Show me the pseudohyphae. Nahi dikh raha. If you're talking about trichomonas, show me that pear-shaped organism or that kite-shaped organism that you should see. Nahi dikh raha. These are visual organisms. If you would have been talking about a bacteria, I would have said, show me the cocci and the bacilli over here. So these are things which you see. Whereas when some of you thought viruses, are viruses seen on light microscopy? Viruses are never seen on light microscopy. Viruses dekhna hai, so you'll always have to do some very advanced techniques like electron microscopy. So human papilloma virus, why did you think virus to yahan nahi dikh sakta? Possible nahi hai because I can only see that on EM. So why did all of you think? Because maybe you thought that virus nahi dikh raha, but uska change dikh raha hai. I can see the change caused by it. That is, I can see coilocyte. Firstly, some of you are asking me, can HPV affect the vagina? HPV can affect any squamous epithelium of the body. Cervix, yes. Vagina, yes. Anal canal, yes. Esophagus, oral cavity, skin. Anything that has squamous epithelium, human papilloma virus can attack. So vagina can be affected. Can it present as a red friable mass which will be bleeding? Definitely yes. Presentation wise, you guys are right. But coilocyte wise, you guys are not right, because this is not how a coilocyte looks like. Firstly, like I said, human papilloma virus likha hai, so they'll give you some kind of a squamous epithelium in the picture also. Na? Here, what kind of cells have they given you? I'll give you two options. Select one of the two. Have they given you pink looking cells, or have they given you totally clear, khali looking cells? Clear cells or pink cells? They are total clear cells, because when in the vagina you start seeing totally clear cells, you start suspecting a clear cell carcinoma. And once you suspect a clear cell carcinoma, you know that the reason for it is DES. What is DES? DES is a drug which is no longer in use. Once upon a time it used to be in use, and DES is diethyl stilbestrol. Diethyl stilbestrol, once upon a time, like I said, yes, this used to be one of the important ones that we had, and one of the hormones which was given to pregnant mothers, so that hormonal preparation, so that their delivery and their pregnancy would go smooth. So this was given to pregnant mothers, and their delivery procedure, their pregnancy, everything would go nicely and smoothly, and they would give birth to children via a normal vaginal delivery. So everything went fine in the pregnancy. So either they gave birth to a girl or a boy. Especially they realized that when they gave birth to a girl child, at that point of time, not much of defect was noted, but later on, this girl child, we saw that at the age of say 20, 25, she was having clear cell tumors of the female genital tract. like clear cell cancer of the vagina, clear cell cancer of the cervix. These clear cell tumors started happening in this girl child. So nothing was per se happening in the mother, but definitely defect was happening in the child. So that is why they started calling them DES daughters. And that is when they realized it, and they said that this drug should be discontinued in pregnant mothers, and now it's no longer given. But whenever you get a question of a clear cell tumor in a vagina, you have to answer it as DES. I hope that is okay with everyone. Yes? Okay, so since we are doing some really important must know questions, that's the next one. Just changed the order of the questions a little today. Had to ask you first, but I started with the GIS, so never mind. Here you go. 25-year-old female presented with swelling in front of the neck. TSH was elevated. Biopsy shown below. Which of the following is the possible diagnosis? Graves, Hashimoto's, medullary carcinoma, papillary carcinoma, and okay, most of you. Okay, so some of you might have diagnosed it on the basis of the picture, which is quite classical. Some of you also might have looked at the hormone profile. TSH was elevated. When TSH levels are said to be elevated as shown over here, so I by default know that maybe T3, T4 was reduced. T3, T4 reduced hoga, so as a feedback mechanism, TSH is elevated. So basically I'm dealing with a case of hypothyroidism is what my clinical impression over here is. Hypothyroidism cannot be Graves. Graves is hyperthyroidism. It's a toxic disorder, hyperthyroidism. When I talk about medullary and papillary, they are carcinomas. I should have seen malignant cells over here. What I'm seeing, yes, and carcinomas clinically also, they tend to be euthyroid usually. Euthyroid usually, not always, but yeah, usual scenario. Hypothyroidism wala only disorder seen over here is Hashimoto's. And what are the things that I have to look out in Hashimoto's? See, ideally every slide in pathology I know is pink and blue, but this is, what can I say? I can just say it is more pink and more blue. That is what I can say to you. Why do I say more pink and more blue? I think the differentiation over here between the pink and the blue is quite evident in comparison to others. So what is the pink and what is the blue? The blue things that you are seeing over here are nothing but the lymphoid follicles. So if you look very carefully, when you look at the word Hashimoto's thyroiditis, it's definitely going to have an element of inflammation. What element of inflammation? It's going to have lymphoid follicles, lymphocytes honge. Not just like few lymphocytes, so many lymphocytes that they are forming a follicle. They are forming an entire follicle and not a regular follicle. Why does this follicle look lighter in the center and darker at the periphery? Again, lighter in the center, darker at the periphery, because they are, what is the light thing that they are forming? They've become such proper follicles that they're even forming germinal center. You'll say, ma'am, ye to almost, it's looking like a lymph node. Exactly, that is what happens in Hashimoto's thyroiditis. Within the thyroid, you start seeing so many lymphoid follicles that it actually starts looking like a lymph node that has gotten trapped between a thyroid. So much of lymphoid follicles with the germinal centers, that is the blue area. Now you'll ask me, what is the pinkish area that we have? That's obviously the thyroid. That's obviously the thyroid follicles. So now I know why am I calling it thyroiditis, because the element of thyroid is also there and inflammation is destroying it. Inflammation matlab lymphoid cells. Anything else which is said to be the hallmark of Hashimoto's? Anything else? Before that, I'll also show you one more picture. See, like I said, very characteristic photo will come. One end of it will be very blue. Other end of it will be very pink. The blue wala will be the lymphoid area and the pink wala will be the thyroid area. But if someone asks you, very good, what is the hallmark feature? The hallmark of Hashimoto's is a Hurdle cell. So it's time to make it even more pink. Means, what do I mean by that? When I talk about a Hurdle cell, these big pink cells. These big pink cells are all the Hurdle cells. So what is a Hurdle cell? You'll say, ma'am, is this something new? Not exactly. Did you look at these thyroid follicles? These thyroid follicles which were there, and these were the regular follicular cells. These regular follicular cells can undergo a change, and that change is known as a Hurdle cells. Many of you are calling it a very fancy name known as oncocytic cells. Many of you are calling it oncocytic cells, and I agree with you. In fact, why not? Now that you've told me this, we'll revise all the names for it, because any name can come in the exam. There are 4 names given to it. 2 names go by scientists. One is known as Hurdle cell, other is known as Ashkenazi cell. One is known as Hurdle cell and the other is known as Ashkenazi cells. In fact, there's a very interesting story. These were the 2 scientists, and this also teaches you a very important life lesson. See, most of us know it as Hurdle cells, so all the recognition went to this scientist only. But practically, who actually gave you the composition of these cells? Actually, they were described by the scientist Ashkenazi. Hurdle cells, Hurdle was the one who first saw these cells. But that time he used to think that they are some parafollicular C cells. He did not know the composition. Who gave us all the details about it was Ashkenazi, but Ashkenazi never got the due for it. The unsung hero in this story is this. So that also gives you a life lessons that many a times you do some work, but someone else will take the credit. And that is exactly what has happened in this case. So this is very famously known as Hurdle cells, also known as Ashkenazi cells, also known as, so these were the 2 scientist names. These are also known as oncocytic cells. Oncocytic cells, and these are also known as oxyphilic cells. So first, what does the word oxyphil tell me? That they are very, very pink, and I agree, they are extremely pink in color. Oncocytic क्यों बोला? Anything that is labeled as oncocyte means is very, very rich in mitochondria, and that will definitely be a question that they will ask you. Which organelle is a Hurdle cell very, very rich in? And that is going to be mitochondria. Now that you've studied this, so Hashimoto's is what? Hashimoto's is a lot of blue, which is lymphoid, a lot of pink, which is thyroid, and also a hallmark cell, which is Hurdle cell. What about the gross? The gross is always famous for a diffuse enlargement. Remember Hashimoto presenting as a solitary nodule? Very, very, very rare situation. It does not come as a solitary nodule. It comes as a diffuse enlargement of the thyroid gland. Clinically, how does the patient come? Patient comes with features of hypothyroidism. Having said that, yes, done with this, and let's move ahead with the next question. So I think this was an easy one. We have an answer in front of us, Hashimoto's. Okay, having said that, this is the next question that we have, and read it, analyze the image, let me know the answer. 36-year-old woman presents with erythematous, painful subareolar mass. The patient undergoes IND and the specimen is sent to pathology. Foci of squamous epithelium is seen in the lactiferous ducts. Noted in the clinical history, and the patient is a smoker and has had these recurrent abscesses, and every time this patient undergoes IND and antibiotics for the same. So what is the best diagnosis? Okay, so before that, I think we've got a few questions pending. Someone had asked me also seen in, you are asking me about Hurdle cells. Hurdle cells, yes. So if you ask me, ma'am, is Hurdle cell specific for Hashimoto's? No. Hurdle cell is a non-specific finding. You can even get it in tumors. You can even get it in cancers. It's not something, so I never make a diagnosis just looking at Hurdle cells. I have to look at the entire picture. I told you that you will have to look at the lymphoid follicles also, you will have to look at the thyroid also, and then if you get Hurdle cells, well and good. If I just give you picture of one Hurdle cell, you can never make any diagnosis. So it is not at all going to be specific. I hope that's sorted. Coming back, yes, for those who answered this question, this is a classical case of SMOLD, and I think there were some very classical points. What is SMOLD? SMOLD stands for that in the lactiferous duct, what kind of an epithelium does it have? Lactiferous duct either has a cuboidal or a columnar epithelium. These are the 2 possible epithelia, cuboidal or columnar, but I am saying that in the lactiferous duct, the epithelium is changing. Metaplasia ho raha hai into squamous epithelium. So squamous metaplasia of the lactiferous duct in the exam can be written as SMOLD, can be written as SMLD, and can be written as Zuska's disease. Squamous metaplasia of lactiferous duct, reason for this is told to be smoking. So when I come back, I think everything was mentioned. My patient was a smoker. My patient was showing foci of squamous epithelium in the lactiferous duct, and then they've also given you an image which is more or less of a formality here. Sometimes you will get a question where the image will not be something that will be the catch point. Image will be more of a supporting cast hoga. So even if you read your history well, you will be able to solve your question. So over here, yes, I can see these pink color flakes. So I definitely know that, yeah, this is the squamous epithelium that I'm seeing out here. Right? Okay, having said that, let's move on to, I think the questions are done. Questions done for the day. And this is one last question that I've got for the second year students and the students who just joined in. So this is a spotter question. NEET PG students, I know you guys are well versed with this question, so I don't expect you to know or not know. I'm assuming you know. I just want you to the new students to tell me, or the fresh second year students to tell me. Very good. So if I'm seeing an FNSC, and this is quite a young female, 30 female, and the clinical impression is that in the breast there is a firm mobile lump. It's mobile, so I don't see any features of cancer here, neither is her age of a cancerous lesion. And FNSC shows me this kind of a cluster. So that's a classical, very good, like I said, spotter image. That's a staghorn cluster. That's a staghorn cluster, and that is something that you see in a case of fibroadenoma. Now the NEET PG students will tell me, okay, other than staghorn cluster, what else do I see on the FNSC of a fibroadenoma? Staghorn cluster to ho gaya. What are these tiny dot cells in the background? These are all the bare nuclei. These are all bare nuclei. So there are a lot of questions that come on this, that fibroadenoma, which is a benign breast disease, benign condition. What does it show you on FNSC? So it shows you the staghorn clusters, and it shows you these tiny empty looking cells. These are the bare nuclei. Well, so this was just a spotter, a higher power for those who want to know. Again, staghorn cluster and these tiny cells, these are the bare nuclei. Okay, having said that, first part of the questions are done, mixed bag over. Now I'll just quickly make you go through whatever's planned for the sessions for the coming month. So starting tomorrow, yes, starting tomorrow, firstly, this is the calendar that we'll be following. These are the dates which I've crossed out where the classes of Kickstart Morning. So Kickstart Morning, for those who don't know, and for those who know also, the timing remains the same. The venue remains the same. It's going to be on the Unacademy app, 7:30 a.m. Duration will be same, 50 to 60 minutes. These are the days on which classes would not be there, and these are the days on which the classes will be there. I'm only giving you, before you start asking me, ma'am, isme kuch to missing hai, we have not studied, sab kuch nahi cover hua, so I'll tell you why. Firstly, starting tomorrow, we were left with an immunity mixed bag question that happens. For Feb 2nd morning, there's a special class for the FMG students for their upcoming exam. Feb 3rd, we have spore forming bacteria, matlab Bacillus and Clostridium, top 15 questions from previous years. Then we come to a little bit of path, vasculitis. Then there are 2 days which I've kept as a mega revision of the tumors. Mega revision matlab renal, liver, vascular, lung, means on these 2 days, 5th and 7th, I will be teaching you in the Kickstart morning session, but I'll be giving you a lot of questions over Telegram also to attempt. So this is going to be like the mega revision, mega weekend for all the tumors that we have. I think end moment, we always need a revision of nephrotic, nephritic, the images, the salient features, immunofluorescence, electron microscopy. So I've kept one day. The table of myocardial infarction, very important. Cardiomyopathies ka clinical profile, again questions. Then I've kept at a stretch so that there's no break. I've kept a gram-positive bacteria we've done. Spore forming ho gaya. I've kept 5 days back-to-back for gram-negative bacteria. All MCQs to know about these. We'll do a mega revision of all the gram-negative bacteria. Moving on, we have one class on lung tumors, one class on brain tumors, and everything to do with brain, like all the tauopathies and all those recent important questions jo aate hain, which we have to revise. GI polyps, I don't need to emphasize how important is it. Many of you had requested me for 2 things. One is salivary gland tumors and also soft tissue tumors. So the 2 pathology things which we don't read too much, I'll be taking them up together. Salivary gland and soft tissue one day, and then I've kept 5 days for the lab techniques which many of you requested. First is genetics wala, polymerase chain reaction, CGH and karyotyping. Then there's one class on histopathology processing and FNSE, one class on immunofluorescence, one class on the very famous electron microscopy, which all of you have become very fond of after the last INI CET. And since some of you had requested that, ma'am, please conduct one session on the antigen antibody reactions in microbiology, ELISA and all of those, precipitation, on whatever those reactions are. So I've kept one day for that. अब इसमें क्या cover नहीं हुआ? There are 2 to 3 things that have not been covered under it, that is virology and parasitology. So talking about parasito, and the third thing that happens to be is hematology, right? So these are the things that you would want to ask me that ye kaise cover honge. So I've decided, because February is anyway a month where we have less number of days and we have to pack everything in this, because we have the exam that is coming up. So I've decided that a little change out here. Parasitology I'm going to conduct in the second week of Feb. Parasitology, second week of Feb. Hematology I'm conducting in the third week of Feb. And virology, because although because of COVID, all of you think that viro बहुत important है, but viro से इतने questions आते नहीं है. So virology I've planned for the first week of March, first 3 days of March actually. Won't go beyond that because you have an exam. So that's a little bit of alteration that I've done. So these will be posted on the YouTube channel. I'll be taking them in the afternoon on YouTube so that we can finish our course in a quicker manner, because everything can't be done in the morning classes. So these I'll be taking up in the afternoon around 2 o'clock or 3 o'clock. That will be the time, second, third week of February. Acha, now I can read your comments. And next, so everyone will have to give, whether you do from India or whether you do abroad. Next you'll have to give. And Dr. Amit, you couldn't watch last month wala. In case you guys have missed the January Kickstart morning session, then take it as a target कि अगर for example 20 classes हुई हैं, तो every day start seeing 1 and you'll be able to catch up on the previous ones also. That's an easy way to go about it. Okay, Dr. Advaita, either Navi Mumbai or Belgaum, either of the two I would go for. How many questions should you practice daily? If you're practicing and if you're targeting the March 12th wala exam, then you have to practice at least, I would say 70 to 80 questions. ज़्यादा लग रहा है तो at least 50 तो minimum है, but I personally feel 70-80 तो cross कर जाओ, because now you're almost in the last month and you need that much of practice, which anyway you'll do. Like for example, today if you plan to study, say you've kept 1.5 day for dermat, or you've kept 1 day for psychiatry, if you sit down to solve questions of psychiatry, वो easily इतने हो जाते हैं. So I think 70-80 target you'll anyway accomplish with ease. You should not go below that at any cost. Okay, Dr. Advaita, in terms of the infrastructure and also in terms of the academics, Belgaum is a better option, definitely. But again, depends on if you're comfortable. Some people do face certain language issues, but otherwise, if that's not a concern, because eventually for 3 years and beyond, you do get comfortable in the place. But in terms of the academics, it's definitely a better college. Okay, FMGs can attend? Why not? Of course, your exam is in June, but that doesn't mean that you shouldn't be doing this kind of a crash course. You definitely should be doing this, and it will be helpful for you as well. Tomorrow morning class, all these classes will be on the Unacademy app, and tomorrow morning the scheduler is in front of you. Immunity mixed bag. So we had already done immunodeficiency disorders, we've already done amyloidosis. अब थोड़ा बहुत और जो रहता है regarding immunity, that we'll catch up on tomorrow in tomorrow's class, morning 7:30. Just a quick update, because today happens to be 31st, so that's the last day of this Unlock 20, which was applicable only today and tomorrow. So in case you guys, now I have to give you the plan for plus classes. Plus classes, especially for the FMG students, there's a batch that I'm starting from February 2nd. From February 2nd to Feb 25th, there is a batch for pathology which will take care of 44 hours of pathology, and every day just 2 hours. So 4 p.m. to 6 p.m. every day is the time slot that we've kept. and total of 44 hours of path I'm covering under it. Further, I've divided it chapter wise, so we are going to go in a proper chronological order. 42 hours I'll be teaching you full theory, and then in the end for 2 hours I'll be taking a proper grand test. And in fact, all 44 hours will be more of MCQ discussion of all your previous year questions. So this is the batch that I'm talking about, the FMG batch, and this is what we are starting with. 2nd of Feb को start हो रहा है. Timing I've told you 4 p.m. to 6 p.m. So in case you wish to purchase, today is the last day of the same. Patho Live happens to be the code, and yeah, so all the students who were asking me about FMG batches, there you go. How many histopath questions? See, आजकल ना you cannot determine. First of all, you're not even asking me path. You're asking me path में भी histopath questions कितने आते हैं. See, these days a lot of integrated questions are coming. So it's very difficult to even categorize whether the question has come from medicine or whether it's come from path or whether it's come from surgery, because everything is given in one question. So that's the beauty, you can say, of these clinical questions, that it takes into account many subjects. So you can never say that, histopath will get me 10 questions or 12 questions, but do not think of, leaving it, because if a histopathology image has come, then sometimes that is the catch point, and you don't want to lose out on your marks if you are not knowing an image. I always say this, I think many students who've been with me from the beginning must be sick and tired of listening this line from me. Diagnostic subjects के images मत छोड़ के जाना. Diagnostic subjects मतलब radiology, pathology, microbiology, any clinical sign like in ophthalmology, the fundus images, anything that leads to the final diagnosis of the patient. Like radiology is a diagnostic branch, pathology, micro, lab culture, lab microscopy, these are all diagnostic things, because finally that is what clinches the diagnosis in a patient. These are the images that you'll get in the exams. So never leave out on diagnostic subjects ka images, most important. Yes, Kickstart is NEET PG questions. We discuss both. Questions hote hain, and then we discuss the theory relevant to it. So this is actually, why is it such a tight and a packed schedule? Because it's for the March exam students. Otherwise we would have gone at a nice slow pace and discussed small topics daily. But why does it look so power packed? Because exam is coming up and we want to revise as much as possible before the exam, and hence it looks the way it is. Okay. Right, guys. So thank you so much for joining in. I hope all of you've benefited from the questions and you got clarity on how would we be proceeding in the month of Feb. So hoping to see you all tomorrow morning, 7:30, Unacademy app. Thanks a lot. Study well. Last 40 days left. I know the anxiety and all the negative things are kicking in, but hopefully, since all of us will be together in this, I hope we are able to, in some way or the other, we are able to, sail through this together. So do let me know. Also, I would be talking to you tomorrow morning about this. I'm also planning to put up quizzes regularly in the last 30 days, because I think as many number of questions that you can revise at this point of time, more is less actually. So as many that come in your way, you are supposed to revise. So starting tomorrow, I'm planning that for the next 30 days, we'll have a more regular MCQ discussion on the Telegram group in the evenings. Anyway, I'll be talking about this tomorrow, and we'll finalize a time that suits everyone, so that everyone can come together for 5-10 minutes, discuss a few questions on Telegram, and yes, I think it'll help us. Thank you. Thank you so much for joining in, and have a great day. Study well. See you all tomorrow morning. Thank you.